Hello everyone. I am Dr. Manaswi Gupta, consultant physician working in Hisar, Haryana. So today we will be discussing about rationality of combination of SGLT2 inhibitors and DPP-4 inhibitors with in combination. So first thing first, SGLT2 inhibitors, this is a class of novel oral glucose lowering agents that mediates glucose lowering action by increasing urinary glucose excretion via inhibition of the sodium glucose or transporter 2 in the proximal tubule of the kidney. Because of the progressive deterioration of beta cell function that characterizes type 2 diabetes, so a pharmacological action that is independent of pancreatic beta cell function makes SGLT2 inhibitors suitable to administer at any stages of the disease course. However, SGLT2 inhibitor resulted in 7.8 times increase in plasma glucagon increase, which was accompanied by a 17 to 30% increase in endogenous glucose production. So the latter has been estimated to offset approximately half of the glucose excreted in the urine as a result of the drug. So the salutary effect is its ability to act independent of insulin secretion and action and render it suitable to administer at any stage of the disease course. DPP-4 inhibitor exerts its glucose lowering effect by the elevation of incretin hormones and subsequent augmentation of glucose dependent insulin secretion and inhibition of glucagon release. Combination of these agents has potential to show the additive glycemic control due to their complementary effects. DPP-4 inhibitor exerts its glucose lowering effect by the elevation of incretin hormones and subsequent augmentation of glucose dependent insulin secretion, thus reducing hyperglycemia while minimizing hypoglycemia. They do not induce weight gain and have proven their CV safety in several large prospective studies. Rationale for combination treatment options in type 2 DM are, there can be multiple metabolic defects observed with diabetes. There can be progressive nature of the disease, limited efficacy of monotherapy, need of potentially preserved beta cells, lack of durable response, which with the initial monotherapy, glucotoxicity, that is hyperglycemia begets hyperglycemia, and risk of microvascular complications with poor glycemia. There is a strong rationale of combining DPP-4 inhibitor and a SGLT2 inhibitor because the two drugs exert different and complementary glucose lowering effects. This combination is speculated to prevent the compensatory increase in postprandial glucagon level. DPP-4 inhibitor, being a potent glucagon lowering agent, will counter this potential increase in EGP or glucagon or both. Thus, combination therapy appears appealing and expected to be synergistic in reducing HbA1c. Moreover, the pharmacokinetics and pharmacodynamic studies suggesting no drug-to-drug interaction between SGLT2 and DPP-4 inhibitor make them a pharmacologically suitable combination. Metabolic studies with SGLT2 inhibitor demonstrated to improve peripheral insulin sensitivity and beta cell function. Theoretically, they could be used with any of the existing glucose lowering agents in patients with type 2 DM, except GLP-1 receptor agonist from metformin to insulin. So EMPA and LINA combination with complementary mechanism and its pleiotropic benefits may be suitable option across a range of patients, including those with established atherosclerotic vascular disease or high risk established heart failure or CKD due to the tolerability of the combination in addition to the potential benefits of EMPA on CV and renal outcome, and no increased risk of heart failure with either agent. According to the study, early achievement of HbA1c goal that is less than 7% with EMPA and LINA could reach target HbA1c at 12 weeks compared to monotherapies. Since patients with type 2 DM may be at a risk of non-adherence due to the complexity of the treatment with multiple medications for the condition, in addition to the need for treatments for comorbid conditions and the requirement for self-care activities. The use of an FDC therapy could simplify individual treatment regimens for diabetes and reduce the risk of non-adherence. Single pill formulations has also shown to improve approximately 12% higher adherence rate compared with loose dose treatment regimens in a systemic analysis of studies over a period of almost 10 years. Several studies conducted so far with the combination therapy of SGLT2 inhibitor and DPP-4 inhibitor find them an effective tool of HbA1c lowering without provoking further hypoglycemia. Associated weight loss reduction observed with this combination is an added advantage over DPP-4 inhibitor monotherapy. Interestingly, some studies also found reduced rate of genitourinary infections associated with the combination therapy compared to SGLT2 inhibitors alone. So, Ampalina is available as first-in-class treatment in SGLT2 inhibitors and DPP-4 inhibitors combination group of drugs. At week 24, Ampa and Lina with a dosage of 25 mg of empagliflozin and 5 mg of linagliptin showed statistically significant HbA1c reduction. HbA1c decrements by Ampa and Lina combination has demonstrated almost 1.81% HbA1c reduction at HbA1c baseline of more than 8.5% at 24 weeks. Change in FPG reduction with Ampa and Lina was almost 32.2 at baseline FPG of 156.7 at week 24 and maintained at week 52 in metformin treated groups. Higher percentage of patients achieving HbA1c less than 7% were reported for both single pill combination versus AMPA 10 of 10 mg dosage. Early achievement of goal on the FTC arm of AMPA and Lina could reach target HbA1c at 12 weeks compared to monotherapies. In the add-on to metformin trial, confirmed hypoglycemic adverse effects occurred with an incidence of 2.2 and 3.3% with empagliflozin linagliptin 10:5 ratio or 25:5 mg. A reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when a DPP-4 is added, perhaps because of a better glucose control, although other possible mechanisms remain to be investigated. A reduction in the incidence of genital infections associated with SGLT2 inhibitors has been reported when a DPP-4 inhibitor is added, perhaps because of a better glucose control, although other possible mechanisms remain to be investigated. This unique combination lends itself readily to early treatment intensification because of good tolerability, low risk of hypoglycemia, possible weight loss, and minimal treatment burden. DPP-4 inhibitor and SGLT2 inhibitor fulfill a need for pharmacological agents with complementary mechanisms of action that can be used in combination to improve glucose control in a wide spectrum of patients with diabetes with a low risk of adverse events such as hypoglycemia or weight gain and the potential cardiovascular protection. So in summary, AMPA-LINA combination provides a robust HbA1c reduction and 2 to 4 times higher odds of patient reaching the goal HbA1c compared to individual agents with low hypoglycemic risk. The combination offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight gain. Additionally, it would reduce the daily pill burden in this population, potentially improving adherence to and optimizing the benefits of treatment of diabetes mellitus. Thank you.